We're now going to look at some principles of management of hypothermia. Now, obviously, people that are too cold need warmed up again. And the way you do this is going to depend on what facilities you have available and the clinical need of the patient. But basically, there are two ways that you can rewarm patients. The first is passive. And passive means that you're using the body's own metabolic activity. You're not giving external sources of heat. So the idea in passive rewarming is that you prevent the patient losing more heat and you allow their own metabolic processes to warm them up. That's what we mean by passive rewarming. The next is active. And in active rewarming, we actually give the patient heat in some way. External heat sources. Now, active rewarming can be divided into two types: active external rewarming and active internal rewarming. Now, active external rewarming means that you put in heat from some other source into the patient via the surface of his body. So, for example, if you were in a remote area and you had a hypothermic patient, you might actively rewarm them by putting them in a sleeping bag with someone who is warm, if you didn't have any external heat sources. And then they would take heat from that person's body. So huddling is a kind of active rewarming principle because they're getting heat from other people. And sometimes that might be the only option that's available in some remote circumstances. But a principle of active rewarming is that we should warm the trunk of the body first and not worry about the hands and the feet and the legs and the arms. Now, the reason for this is that if you rewarm the hands and the feet and the legs and the arms, the periphery of the body, then that's going to cause a vasodilatory response. And this includes the arteries and the venous vessels. They'll dilate. And what that means is if they dilate quickly, because arms and legs do warm up quickly because they're fairly thin, if there's a vasodilation in the arms and the legs, then all the cold blood that's stored in the arms and the legs can rush back to the centre of the body. And that means you essentially get a bolus of cold blood arriving back at the heart. And the heart does not like this. It has very great difficulty coping with this gross homeostatic change. And that can result in fibrillation. So a principle is warm the trunk first and worry about the peripheries later on. In fact, the peripherals, as the trunk rewarms, the blood will gradually go out to them anyway, so that they'll take care of themselves. Some patients, as we'll see later, occasionally need warm baths to warm them up. Again, you would put the trunk in and leave the arms and the legs out of the water in this circumstance. And I don't know if you know, but if your hands have been cold, hot water is very, very painful, very irritating. So you need to start off with warm water, say at 30 degrees centigrade, and then build up to warmer water at, say, 40 degrees centigrade. You can also use warm air methods as well. But of course, always remember that active rewarming is potentially dangerous. It can cause very rapid changes in homeostasis, and the patient must be managed. The heart must be managed. There must be good cardiac management, and there must be good metabolic management. But still thinking about the principles of rewarming, active internal rewarming. Now, this could be inhalation of warm air. It could be giving warmed intravenous fluids. It could be pouring warm water into the stomach and then letting it run out again. It could be hemodialysis. It could be putting warm water into the bladder and letting that drain out again. Now, all these active internal rewarming mechanisms are in the book. In practice, they're not used that often. What I want to do now is talk about the principles of how we decide how we're going to rewarm a patient. This, of course, will depend on your circumstances and the patient's condition. But the first principle I want to introduce, oh, by the way, before I do this, I should actually say, this is not research-based. There is no particular research policies on this. So it's very much a matter of judgment. So these principles are just to inform judgment, really. They're not absolute rules by any means. But the first is that if a patient cools down rapidly, we want to warm them up more rapidly. If a patient cools down slowly, we want to warm them up slowly. Now, for example, if someone falls into cold water and they get an immersion hypothermia, they can lose body temperature very quickly. But there won't have been time for the development of the cold-induced diuresis to lower their blood volumes. There won't have been time for the development of the edema and the removal of fluid from the blood into the tissue spaces to lower blood volume. So despite the fact that the patient is hypothermic, they should be normovolemic. And the key thing here is that when someone is cold, when someone is hypothermic, there's a risk of cardiac arrest. And this is what we want to avert. So the first thing is to stop someone getting colder. And when you actually take someone out of cold water, they can carry on cooling down for quite a while. So ideally, if someone is rescued from cold water, in acute hypothermia, rapid onset hypothermia, we want to warm them up quickly. And a good way to do this is to put them in a bath of warm water. As we said, 30 degrees centigrade at first, or even cooler, and then bring that up to about 40 degrees centigrade as the patient is able to tolerate it. Only warm up the trunk. The arms and the legs should be sticking out of the bath of water, because we don't want to cause the vasodilation in the arms and the legs that will let the cold blood return back to the centre, possibly causing cardiac arrest. So warm the trunk up first. Then when the patient's temperature is stabilised or is starting to warm slightly, we can then go on to a passive rewarming, just letting them warm up with their own metabolic activity. Now when someone has cooled down more slowly, we want to warm them up more slowly. And the reason here is that because they've cooled down over a longer period of time, there'll be acidotic and there'll be metabolic changes. For example, the sodium and potassium pump on numerous cell membranes might not be working properly, and there's a risk that the patient could be hyperkalemic. These things need correcting, but we want to do them gradually, not in an abrupt way. If someone is cooled down slowly, there'll be a loss of blood volume. They'll be hypovolemic. And these things all need correcting, but we can't correct it quickly because that'll put too much strain on the cold heart, and the patient will essentially get an acute congestive cardiac failure. And again, that can lead to a cardiac arrest situation if the heart is already cold. And normally we want to warm these patients up in a hypothermia which is well established, an insidious onset hypothermia, fairly slowly. Now old people, a lot of people say don't warm them up quicker than 0.5 degree per hour. Younger people, you might want to warm them up quicker than that, maybe 1 degree or 2 degrees centigrade per hour, because remember the risk to the heart is dependent on how cold they are, and we don't want them to have a cardiac arrest. So they're two fairly basic principles. Another few more general principles. Passive rewarming in mild to moderate cases of less than 12 hours duration is a reasonable rule of thumb, unless the patient cooled down very quickly, in which case we would want to warm them up more quickly. Now, passive rewarming in core temperatures above 30 to 32 degrees centigrade. Now, if young people have a body temperature of 30 degrees centigrade, they can warm themselves up with their own metabolic processes. In older people, it probably needs to be as high as 32 degrees centigrade. So passive rewarming can work in these circumstances. And unless there's any cardiac dysrhythmias, then this is probably the best strategy to choose. But if you're warming someone up using their own metabolic processes, here's another principle. If the body temperature does not start to rise, or the patient is persistently hypotensive, if they have a low blood pressure, then go on to an active form of rewarming, because the passive form of rewarming is not working if the body temperature does not start to rise. Now, whenever anyone's temperature is low, say below 30 or 32 degrees centigrade, the metabolism will also be slow. This means that there will not be enough heat generated by the metabolism to warm the body up. In that case, the patient will definitely need actively rewarmed. Let's think about further principles of treatment now. We've already said that a major principle is to prevent further heat loss. So we need to put the person in a situation where they're not losing any more heat, ideally in a warmer environment if there's one available. Of course, if the person is wet, they'll be losing the latent heat of vaporization from the surface of the skin. So a priority is always to dry these people. Get wet clothes off, get them dry, and get dry, warm layers next to the skin. Several layers of clothing to trap air, which of course is a good insulator. We also want to reduce heat loss from the head, because the head is very vascular and a lot of heat can be lost from there. So think about wearing hats and things like that. Space blankets are these shiny blankets. They're quite good for reducing the amount of heat that's lost through radiation, but not particularly good for preventing heat loss from conduction. So you use them in combination with other blankets. We can give these patients warm foods and warm drinks, but we should not give them hot foods and hot drinks. Now, why do you think it is that it's probably, almost certainly, a bad idea to give a hypothermic patient hot drinks and hot food? We can give them warm drinks and warm food, but not hot. Well, I can't guarantee this is right because, again, it's not based on research. But there are certainly cases of people that have been moderately hypothermic, maybe 33 degrees centigrade, who've been given hot cups of tea, and the patients have died. And what may be happening here is the hot tea causes vasodilation in the stomach, and that's going to reduce the blood volume available to circulate around the heart and the lungs. That's probably one factor. But another factor is when you take hot tea or a hot drink, very often you feel hot. And this is because the central heat causes a global peripheral vasodilation. And if someone's hypothermic, that is going to cause dilation of the blood vessels in the limbs. And that's going to cause the cold blood from the limbs to come back to the heart as a bolus of cold blood. And we've already said that this can cause ventricular fibrillation. So warm food and warm drinks to warm them up gradually, but not hot food and hot drinks. We want to avoid washing them unless they're incontinent, because again the water will cool them down with the latent heat of vaporization. We give them carbohydrates because carbohydrates are good for shivering and non-shivering thermogenesis. It's fine to give them carbohydrates. Don't worry that the patient's going to become acutely, that the high blood pressure is going to be too high, that they're going to be hyperglycemic. It's probably not an immediate problem. Now we need to treat these patients gently. We need to move them gently. And in fact, when we're rescuing these patients, we need to rescue them flat. Now when people were being rescued from the sea, very often the helicopter people would put a band round about their chest and just lift them up. And the feet would dangle as they were being lifted. And these patients sometimes died on the way into the helicopter. Now can you think why that might be? Why might these patients have died when they were in an upright position? Well, in hypothermia, if the blood volume was low and the heart was working inefficiently anyway because it was cold, and you put someone in an up and down the way, then that's going to reduce the venous return to the heart because the blood will be pooling in the legs. And the amount of blood going back to the heart in the vena cava will be less. If there's less blood going back to the heart in the vena cava, then less blood can be pumped out into the aorta. And of course, the first two blood vessels that leave the aorta are the coronary arteries. So that could result in an acute myocardial hypoperfusion, which is life-threatening. So hypothermic patients should be managed and rescued flat rather than sitting or standing wherever possible. And it's hard to say why rough handling can cause heart attacks in these patients or ventricular fibrillations in these patients, but it seems to be true. So move these patients only if you have to, and be very gentle with them. Move them gently, touch them gently, don't rough them up or shake them around, because if you treat them abruptly, then that can cause cardiac arrest. So very gentle treatment is an important principle here. Treat gently. Avoid sudden vigorous movements. IV fluids. Another interesting one here. If the hypothermia has developed slowly, there's a good chance that the patient is going to be hypovolemic. But there again, as you warm them up, the blood's going to move back from the tissue spaces into the blood. So the blood volume should restore itself naturally as you warm the patient up. So that means that a patient may be hypovolemic and you could give them lots of fluid, and then they could go into fluid overload. Alternatively, of course, if someone is hypovolemic, then they do need extra fluids, warmed IV fluids. So again, it's a fairly difficult decision. These patients need monitored very carefully. Ideally, of course, you would measure the central venous pressure if that's possible. So IV fluids if the patient is hypovolemic with a low central venous pressure. But remember, the fluids will restore themselves as the patient warms up anyway. And the cold heart is very prone, as we've said, to the possibility of an acute congestive cardiac failure. Increasing the preload in the heart, if the heart is cold, can cause cardiac arrest. So it's quite difficult to think about how we're going to treat these patients, really. Avoid drugs. We want to avoid drugs because they can't metabolise them. If the liver's cold, they're not going to be able to metabolise drugs effectively. And drugs can build up to toxic levels. And there's no firm evidence that I'm aware of that any drugs are particularly helpful in hypothermia. Although some people do say they should give a bolus dose of antibiotics if infection is likely to be a problem. We've talked about maintenance of IV fluids, and for some reason I've written avoid drugs down twice, so we'll ignore that one on the bottom. Let's think now about observations we're going to make of a hypothermic patient. Well, obviously we want to record things like pulse and blood pressure, and we've mentioned the changes that can happen to those when a patient is hypothermic. Initially the pulse rate can go up, then as hypothermia develops they'll become bradycardic. Blood pressure will go down because of the bradycardia and because of the hypovolemia that you get as a result of the fluid shifts and the hypovolemia that develops in more established cases of hypothermia. I think that's fairly obvious. Respirations need to be observed as well, of course. The rate and the depth of respiration, and we've already said what happens to these. But in addition, the cilia, the little hairs that waft the mucus from the alveoli up towards the trachea, are paralysed. They become progressively more paralysed the more hypothermic someone becomes, especially if they're breathing in a lot of cold air. And this means that fluids and mucus tends to accumulate in the lung fields. And if you do chest x-rays of patients with established hypothermia, the lung fields are dark, they have some opacities because of the accumulation of fluid in the lungs. So we certainly want to know the patient's respiratory state. ECG we've mentioned. The main cause of death in hypothermic patients is going to be cardiac, and cardiac management depends on cardiac observation, and this is absolutely critical. This is one of the absolute tenets of managing hypothermia, that the patient's cardiac state is managed, so they must be on an ECG. And there are characteristic changes as well. I'm not sure what practical use they are, but the main thing is we need to be observing the patient's heart rate. Various blood tests, blood glucose we've discussed. But the blood test that's probably arguably most important is the potassium level. Now, in the cell membranes, between the tissue fluids and the cytoplasm of the cell, there are sodium-potassium pumps. And the efficiency of these will reduce the more hypothermic a patient becomes. And this can result in the accumulation of potassium in the tissue fluids and in the blood. The patient can become hyperkalemic. And when the level of potassium rises, this is going to alter the electrochemical balance across the individual myocardial cells and is going to make cardiac irritability and arrest much more likely. So hyperkalemia carries a much poorer prognosis when the potassium is high. So if we know about this, it may be you have the facilities to manage this, but if not, it means we have to observe the heart very carefully. You could do hematocrit as well when you did blood tests if you wanted to, because there's a loss of water from the blood, therefore the hematocrit would increase. The hematocrit, remember, is the percentage of blood which is cells, and if water is taken from the blood, then the concentration of cells is going to increase and the blood is going to become thicker. Fluid balance charts and urine. Well, we've mentioned the possibility of acute renal failure. These patients should be catheterised if possible, and the urine volumes measured if you consider renal failure. It is a possibility. And also the urine might be very acid, reflecting a systemic acidosis, as we've already discussed. These patients should also be observed for the possibility of frostbite and frost nip, which needs to be managed. If there's no circulation at all to an area, fingers and toes and noses and ears, for example, the extremities, then these tissues will die and essentially become necrotic, frostbite. And of course, don't forget your basic nursing measures like observation and assessment of pressure area status and prevention of pressure sores. So a few principles there of observation in a hypothermic patient. Now, we've talked a fair bit about treatment, but I just want to say a couple of things about treatment of more severe cases when there's a profound hypothermia. Now, we've been through the principle that patients who cool down slowly should be warmed up more slowly, and patients who cool down quickly can be warmed up more quickly. Now, one of the reasons that patients who have got established hypothermia, who've cooled down over a longer period of time, can't be warmed up quickly, is that the heart can't cope with the increase in venous return. So as the blood volume starts to increase, because the fluids are drawn in from the tissue fluid back into the blood, the cold heart just can't cope with the increased preload, and it'll put such a strain on the heart that there's a risk of fibrillation. So in established hypothermia, we want to be warming these patients up slowly, 0.5 to 1 degree per hour. This is especially the case in the elderly, where you want to be much more towards the 0.5 of a degree per hour level. And so this means you might be in a situation where a patient is actually warming up too quickly, and you actually take steps to keep the patient cool so you can warm them up at the rate you want to warm them up at. The problem to balance this against, of course, is the fact that we've said that the more hypothermic a patient is for longer, the increased risk of cardiac arrest there is. But what tends to happen in these long-standing cases of hypothermia, the established cases, is that these patients are generally warmed up really quite slowly. Now, we've already mentioned that the tissues are going to be hypoxic because the hemoglobin is reluctant to give up its oxygen to the tissues. So it won't do any harm to give these patients oxygen therapy if that's available. Ideally, we want to be monitoring the temperature continuously. If not, we'll monitor it every 15 minutes. And remember, of course, we're talking about core temperature measurements here. What we normally do in the intensive care situation, when equipment is available, we actually have a continuously reading electronic rectal probe, which is ideal, but if not, observations every 15 minutes. Now, I want to talk about basic life support and CPR now in hypothermia. Now, this is indicated for the usual indications: an unconscious patient and an absent central pulse. So if you discover a patient who is hypothermic and there is no central pulse, by the way, you might need to record the central pulse for longer, maybe 20 or 30 seconds, because it could just be that the patient is profoundly bradycardic. But if there's no central pulse, then we need to carry out basic life support, CPR, cardiopulmonary resuscitation, until the patient is warmed up enough to decide whether they are dead or not. And as well as that, if there's no pulse in a hypothermic patient, there's not much point trying to restart the heart until you get them much warmer, maybe 32, 33 degrees centigrade. Because when the heart is below 32 degrees centigrade, it's not going to start anyway. Cold hearts, like blue hearts, don't start. So if a heart is hypothermic, or if a heart is very hypoxic, you're not going to be able to defibrillate it. So this means that CPR might be needed over a long period of time while the patient is being warmed, actively warmed. So the principle again is that we don't declare a patient dead until they are warm and dead, because you can do CPR in the absence of a central pulse in a hypothermic patient, and then hopefully you can resuscitate them, you can restart the heart once they've warmed up. If a patient's hypothermic and they do have a pulse, then obviously you would warm them up, and hopefully the pulse rate would increase as the patient warmed up. So I'm just going to show you a clip now, after we've looked at these notes, to point out, to stress the fact that patients must never be declared dead when they are hypothermic. But these notes first, then that clip.